Thank you very much for having me here. You're quite a title when you are talking about something that needs to be resuscitated. So what I'll do in the next 15 or so minutes is just give you a little bit of an update of where we are with EGFR monoclonal antibodies and show you some data for thought. So I'll talk a little bit about EGFR inhibition in combination with chemotherapy, just give you a historical perspective, because this is where we've been trying to use these antibodies, combine the EGFR inhibitor with chemo. Preliminary data for trial that I'm going to tell you about, 0819. I'll show you two other SWOG trials. I'll show you the top-line results from the 0819, and we can discuss both in the talk and the questions any impact for future. So when you think about lung cancer, of course, we're in the world where immunotherapy is going to be used for everyone, but it really doesn't work for everyone, and we do need other approaches. And at least, with chemotherapy, the small molecules, and hasn't been done with osimertinib yet, and I must admit I sometimes keep that drug going with chemo, but here you can see gefitinib in combination with paclitaxel and carboplatin on the left. That's the INTACT-2 trial. And the TRIBUTE trial, which is carboplatin, paclitaxel, erlotinib versus carboplatin, paclitaxel, both of those trials were negative. I can tell you when we did those trials, almost 15 years ago now, we were sure that this would be positive. We had an active agent, but of course it's all about using it in the right patients. There was some hint, by the way, and when you took never smokers, which used to be our surrogate for mutated patients, that if you look on the right, you can see never smokers who, I don't know if this mouse works. Yeah, you can see never smokers, and if you look at the never smokers as a surrogate, probably from EGFR mutation, it looks like the group that got combination chemotherapy versus with erlotinib versus chemotherapy alone did better. You might ask, what about erlotinib alone in those patients? That wasn't done. Well, what about cetuximab and lung cancer? Well, monoclonal antibodies, the idea being that instead of working inside the cell at the level of the tyrosine kinase receptor, we work outside the cell with monoclonal antibodies. And of course, cetuximab, the old ImClone drug, again, 20 years in study, is approved in head and neck cancer, colorectal, never had an approval in lung. The idea, and this was developed actually, and how I got involved in this is being at MD Anderson. This was actually developed by John Mendelsohn, the former president of MD Anderson, where basically the idea would be you could block the receptor with an antibody that blocks outside the cell, inhibits the ligand, either EGF or TGF-alpha, from binding, and then of course it actually engulfs and internalizes the receptor so that it's not available for future interaction. And here's a bit of a structure of this as well. So there was a time when EGFR antibodies were all the rage, and I won't go into a full litany, but of course it was cetuximab, and of course it's panitumumab, also approved in the indications I mentioned, at least colorectal cancer, more fully human. Cetuximab's what we call a chimerized antibody. It's sort of like the Jurassic Park approach. You take the mouse antibody and then you change the sequences to make it 95, 99% human. But of course, those few mouse sequences that remain in there can cause some serious anaphylaxis, especially in certain parts of the country, the so-called Bible Belt. Well, here you can see we actually, and this really was David Gindera when he was chair of the SWOG Lung Committee. We said, what about antibodies and chemotherapy? That might be a use for these EGFR antibodies. We knew that the EGFR antibodies in lung cancer had very little response rate. Of course, the mutations, of course, are targeted by the small molecules because you have a mutated ATP binding site. So what could be the role of EGFR antibodies? So we set out back with SWOG 0342, and for those who aren't familiar with cooperative group lingo, when it's 03, that means that's when the trial was begun. But usually a couple of years before that, too, a long process. But we asked the question with SWOG 0342, what about concurrent versus sequential? We thought maybe there was a problem, given the experience with the TRIBUTE and the TALENT and the INTACT trials I just showed you, with giving an EGFR inhibitor with chemotherapy. You slow the cells down, you make them less sensitive to chemotherapy. Let's look at concurrent versus sequential. So we basically did that. This was a two-arm trial. This is a phase 2 trial. It was randomized, but the arms are not really comparative. It's really just testing two different approaches in 100 patient or more cohorts. Paclitaxel carboplatin with cetuximab for 4 cycles, followed by cetuximab, or paclitaxel carboplatin for 4 cycles, followed by cetuximab. See, here's concurrent, followed by a maintenance. Here's only the maintenance. Well, here were the data, the concurrent versus the sequential. Actually, again, they both looked pretty good, no difference, but the median survival was 10.9 months for one and 10.7 months for the other. You know, that was reasonably good. You know, 10, 15 years ago, in 2003, you'd be pretty happy with a median survival of almost 11 months in lung cancer. That was before 30 months with pembrolizumab, right? So where did we go from there? Well, we then were working with Dr. Fred Hirsch, who I'm sure everyone knows, very well known, now working with the ISLAC. So Fred was into fish, and not the type that you get with the bait and the rod and the reel, though we have used those pictures of him from once in a while. But basically what Fred was doing was he was using fluorescence in situ hybridization, and he really pioneered this technique for EGFR, and the idea was to look to see if you had multiple copies of the EGFR gene. More gene, more protein. It's sort of like the whole HER2 story, right? So FISH positive was considered more than 40% of the cells having 4 copies of the EGFR signal. Of course, you should only have 2, right? You could look at the EGFR, you can look at the ratio. EGFR gene is on chromosome 7, right? And you look for more than 2 copies compared to the centromere, or you can look at gene clusters, and that's what you would call frank amplification. We have more than 15 copies or more. And you know, Fred said, let's look at the data by FISH. Now, it's retrospective. It was that single arm, those studies of 118 and 110 patients. But let's look at them by FISH. And when you look by FISH positive or FISH negative, the results were quite intriguing. For overall response, FISH negative 26%, FISH positive 45%. And if you look at disease control rate, where you bring in the stable disease, 81%. And here are the curves for the 1 to 4 copies versus more than 4 copies. And you can see it looked like both for progression-free and overall survival, either for the concurrent or the sequential, that using FISH as a predictive marker make a difference. So we were very excited. So what did we say? We said, go FISH, right? So we then said, let's do some randomized trials. We were looking for an idea back then. So now it's 05, so here's SWOG 0536. And my former colleague and friend Ed Kim was looking for a trial, so he said, hey, why don't you do this trial, carboplatin, paclitaxel, cetuximab, bevacizumab. You know, we heard from one of the prior speakers, from Jennifer, I think, about the erlotinib, bevacizumab. What about cetuximab, bevacizumab? Recall that there's a little concern about that. Remember the experience in colorectal cancer with those drugs together? So we needed to pilot this if we were going to use these drugs all together, because people were getting bevacizumab at that time, carbopaclitaxel bevacizumab, based on the trial that Alan Sandler had run in ECOG, and Dr. Langer, of course, involved. So the idea was let's do a pilot study. So this was the next trial, 0536. This was run through the cooperative group, SWOG, and of course other groups enrolling as well. 102 patients. This is published in JTO now. Response rate of 54%. Again, a little selection involved, but that's pretty good. Stable disease, 23%. Disease control rate, 77%. The overall survival, 15 months on the median. Progression-free survival, 7 months. So that looks pretty good. Now, did the FISH predict? Not too well in this study, but we said, okay, well, we'll just move forward anyhow. So then we said, let's do SWOG 0819. And as Corey mentioned, this was a mega trial at the time, you know, because it was a trial where we enrolled everyone, but we had embedded biomarkers. And you'll often see this if a statistician comes up to talk to you about biomarkers, he or she will talk about this type of trial, because you take patients with advanced lung cancer, tumor tissue available, and you stratify for appropriate for bevacizumab or not. So it's the endpoint was really, we're actually testing a cetuximab question, and we're going to look at FISH positive cetuximab patients. But we allowed bevacizumab if it was appropriate, and we allowed the physician to determine that, which, by the way, made writing this paper up really difficult because, you had to figure out why did the physician do that. But for the most part, you didn't give bevacizumab to squamous tumors or to patients who were bleeding or had other medical reasons. We looked at smoking status, current or former versus never, and stage of disease. Patients either got paclitaxel carboplatin or paclitaxel carboplatin cetuximab, and the bevacizumab is with the asterisk because you could or could not do that. And it was also always at the physician's choice. It might have been someone who could get bevacizumab and just decided not to. And then for those who got bevacizumab in the control arm, they continued it. For those who got bevacizumab in the treatment arm with cetuximab, they got both drugs. A ton of correlative science. It's still not all done yet. This is 08, so it's almost 10 years now. EGFR pathways, I'll show you that, of course. Well, actually, that's still cooking. Genomic DNA, EGFR polymorphisms, plasma proteomics. But I will show you the FISH data today. The study accrued from July 2009 until June 2014, so 5 years. What is Bev inappropriate? Greater than 50% squamous cell cancer, history of hemoptysis, cavitary pulmonary lesion, documented hemorrhage or a coagulopathy, high INR, non-healing wound or ulcer, patients receiving anticoagulation, regular use of aspirin, non-steroidal anti-inflammatory agents that are known to inhibit platelet function, or other agents. We didn't want anyone to bleed. So the objectives of this trial, and this trial was 1,300 patients, PFS in the FISH positive population. So enroll all patients, but those who are FISH positive, they should do better with cetuximab plus chemotherapy versus the others. And then we wanted to look for overall survival in the study population. And our industry partners really wanted that too. What if it worked for everyone? You might as well give that a shot. So we looked at both. Secondary endpoints, overall survival and progression-free survival by bevacizumab appropriate and inappropriate subgroups, and safety and toxicity. And then before we unblinded, and I think Corey was a member of our data monitoring committee, we asked them, could we do an overall survival in the entire study and for FISH positive for squamous populations? Because Squire, of course, was the drug necitumumab, of course, the approved, and I'll show you a slide for that in a little bit, fully human antibody. And they had seen benefit in squamous, and we thought we'd try to explore that. So here's the study, the original statistical design. You can see the sample size was ambitious, 1,500 patients, one of the largest trials ever done in the cooperative groups for metastatic lung cancer. 618 would have been the FISH positive group, figuring about 40%. And you can see appropriately powered. And here's the consort diagram, you can see the control and the cetuximab groups are pretty equal, which is what you're looking here, both for sex, smoking history, histology, and performance status. We had to modify the statistical design for a number of reasons. One of the arms, each of the arms is being monitored. One of the arms had to close. We also knew that the rate of FISH was only 70%, observed rate of patients with a FISH result was only 70%, meaning some of the patients we didn't get the tissue, and we couldn't, even though we had the patient, we didn't know if they were positive or not for the overexpression. The observed rate of EGFR FISH in the trial was only 41%. It was about what we expected. So we went down to 1,333 patients where we would have 400 of them FISH positive. And so that's the results I'm going to show you now. So here's the data, and the results in the overall population were negative. We expected this, not negative, but equal. No benefit in overall survival to adding cetuximab versus chemotherapy, either in overall survival or progression-free survival. This actually would have been nice if it was positive, but we didn't expect that. Remember, we were thinking the embedded FISH positive population would be positive. Well, here's the results for EGFR FISH positive patients, and while there's a little bit of a trend, hazard ratio 0.83, close but no cigar, the p-value 0.1. This did not meet its endpoint of overall survival in the FISH positive patients. And here's progression-free survival. This actually was the primary endpoint because we thought we'd use PFS, because that's, of course, the pure endpoint before you start crossing over. And here you can see the hazard ratio is 0.91. At least it's less than 1, but not significant. So this study missed its primary endpoint. Oh, didn't mean to do that. Then you look for the bevacizumab appropriate and inappropriate groups, and there didn't seem to be too much difference there, so I'll skip that because I'm running a little long on time. But then in the squamous cell histology group, we then did begin to see something that was somewhat interesting. Interesting, if you look at all squamous cell patients, there was a trend, hazard ratio 0.85 for the blue, the cetuximab group versus not, with a p-value of 0.18. But when you took just those squamous patients who were FISH positive, you can see that the p-value was quite significant, and the hazard ratio is 0.56. It's a subgroup, it's a pre-specified subgroup of the trial, but it does makes for some interesting thought that here the chemotherapy plus the cetuximab might have a benefit. Well, adverse events-wise, as you would expect, cetuximab, the antibodies do not cause diarrhea. Of course, the most recent generation antibodies, small molecules, are better at that, of course, much less toxic in that. But the main thing you look for is rash, and yeah, you got a lot more rash, especially significant rash. These are all grade 3 and 4s. Where does this all fit? Well, here was the FLEX trial. Some of you might remember this plenary presentation at ASCO, I don't know, a lot of years ago. And this was cisplatin vinorelbine cetuximab versus cisplatin vinorelbine, led by Robert Perker from Vienna. And here was the FLEX. So the FLEX, this was unselected, had a hazard ratio of 0.871, and it was significant. Never got approved. So it wasn't enough to get it approved. It was one of these statistically significant, but not felt to be clinically significant enough to go forward. Then there was SQUIRE. Now, there were 2 trials with necitumumab, the fully human antibody, one in non-squamous and one in squamous. The non-squamous was negative, but the squamous was positive. Again, a little bit of a theme emerging here. And here's necitumumab plus gemcitabine and cisplatin. And here you can see overall survival and progression-free survival. And you can see that this trial was positive, 0.84, and it was significant. Not much different than the FLEX data, but with a lot of persistence, Eli Lilly did get this drug approved. Not sure how much it's used in advanced lung cancer. It's available. It's always a question on the list. We can discuss that in the panel. But then in the subgroup analysis, and again, that was done for the FISH, and Dr. Hirsch does not give up on the FISH, and so he did this work. You can see in those patients who were positive for the FISH, the same way we defined it with more copies of EGFR, here's the results of the SQUIRE study, 12.6 versus 9.2 months overall survival, 0.7 hazard ratio, 6.1 versus 5.1 PFS. So here's a randomized trial, subgroup of a randomized trial that looks positive, and then I have another subgroup. This was non-pre-specified, but then I have the pre-specified subgroup of our trial. So could there be some reason if you had a squamous patient and they were FISH positive to use an EGFR antibody? That's sort of what I'm suggesting here. So here's the summary. For the 0819, the co-primary objective, no benefit in overall survival for the entire population. Indication of benefit for PFS in the EGFR switch positive population, but not statistically significant. I showed you that. It was close, but no cigar. Maybe in the BEV inappropriate patients, there was a hint of overall survival benefit. Remember, those are probably mostly squamous patients. But the main finding, exploratory objective in squamous cell FISH positive patients, a significant improvement in overall survival. So where do we go from here? This trial has been completed, acceptable toxicity of the regimen. These data, along with the recent SQUIRE, suggest a role for EGFR FISH, possibly in selecting patients for therapy with EGFR antibodies, especially when bevacizumab is not used. We're still waiting the analysis of the H-score and KRAS. I should have updated this slide. We haven't finalized all those analyses yet, and squamous cell remains an important area. We're actually we have for a while been using the lung master protocol, but of course now immunotherapy is quite the rage. And a lot of people participated in this. The trial was open mostly throughout the U.S. There were a couple of patients that went on in Mexico, believe it or not. And then I just thank everyone who was involved in the trial. This is actually the lung interspore meeting that we had at Yale this last June. And it did get accepted for publication, and you'll see it actually tomorrow or Monday. I think it's coming out in the Lancet Oncology with an editorial that I have not seen yet by Dr. Perker. I'm anxious to see what he has to say about it. But given that he's been very involved in the field, I bet it will find some positive aspects to the trial. Thank you very much.